Hi, I'm Monty Mython, and I'm delighted to be your host today. Many of you will know me as the Professor of Anaesthesia and Critical Care at University College London, but today I'm hosting as the Editor-in-Chief of Top Med Talk. So this is a big day as we're introducing something completely new in a new clinical environment. We as clinicians are getting something new to support workflow in a moment of great need. Something that should improve patient safety, patient experience and patient comfort. Now COVID has highlighted many issues. Our hospitals are full, we have an enormous backlog of surgery, but it's also highlighted that tech is versatile and easy to deploy to simplify users' life. I'm delighted that in addition to today's broadcast, we at Top Med Talk are going to be investigating Portrait Mobile from many different angles over the weeks and months to follow. And we're now going to hear from Professor Salgal, why ward monitoring must be changed, and Dr. Michaud on how to ensure high quality monitoring.
Hello, my name is Bernd Sauge, and I will explain why ward monitoring must be changed. 2% of patients having major non-cardiac surgery die within the first month after surgery. This means that postoperative mortality is 100 times more common than intraoperative mortality. A reasonable question then is, where do patients die after surgery? This is a secondary analysis of the VISION study, including more than 40,000 patients. 1.8% of patients died within the first month after surgery. Where did those patients die? Well, 0.7% died in the operating room, 70% died during the hospital stay, and 29% died after hospital discharge. This translates into absolute numbers of 5 patients who died in the operating room, 500 patients who died during the hospital stay, and 210 patients who died after hospital discharge. The user study showed that more than 70% of patients who died after surgery were not admitted to an intensive care unit at any stage after surgery, meaning that most of the patients who die after surgery die on normal wards. Why do patients die after surgery? There is an association between major postoperative complications and postoperative death, and the 3 complications with the highest attributable fraction are major bleeding, myocardial injury, and sepsis. What does all of this has to do with ward monitoring? The major postoperative complications cause alterations in vital signs, including respiratory rate, peripheral oxygen saturation, heart rate, and blood pressure. The problem is that current vital sign monitoring on normal wards mainly consists of spot checks by nurses every 4 to 8 hours. Why is this a problem? Let's just, for example, look at oxygen saturation and blood pressure. This is a prospective observational study of blinded SpO2 monitoring in more than 800 patients after non-cardiac surgery. And the study shows that 1/5 of the patients had at least 10 minutes with an SpO2 of less than 90. Routine intermittent spot check monitoring missed 90% of the hypoxemic events defined as an SpO2 of less than 90 for at least 1 hour. And only 5% of patients had even a single SpO2 of less than 90% documented in the nursing records. We have the same problem with blood pressure monitoring. This is a study on the incidence and severity of postoperative hypotension after abdominal surgery. And here we see the continuous 15, 30, and 60 minutes below blood pressure thresholds. And for example, almost 15% of the patients had 30 minutes with a mean arterial pressure of 65. Hypotension, defined as a mean arterial pressure below 65, was to be detected by intermittent spot check monitoring in only 21% of the cases. So intermittent spot check monitoring at the moment is a problem because a patient can be fine at 4 in the morning, There can be a clinical event or deterioration at 4:40, and we will only recognize clinical deterioration a couple of hours later during nursing rounds. This results in late recognition of clinical deterioration. Continuous ward monitoring may allow us to identify clinical deterioration or a critical event just instantly. We can then notify ward nurses or rapid response teams, and this would allow early recognition and fast intervention. So in the future, hopefully all of the patients are monitored continuously on hospital wards. All the real-time patient information will be processed, and there will be a command center where clinicians review vital sign monitoring data and can notify wards, ward nurses, or rapid response teams. So to summarize, 2% of patients die within the first month after non-cardiac surgery. 2/3 of those patients die during the hospital stay. Postoperative death are caused by postoperative major complications. Those complications cause alterations in vital signs, and these vital sign alterations are currently missed by intermittent spot check monitoring. So in the next talk, we will learn how to perform continuous ward monitoring, and I just want to close my presentation with the statement that I think we need to be smart when it comes to continuous ward monitoring. So we need to select patients wisely. We need to develop reliable and accurate monitoring technology. We need to handle alarms in a smart way and in the clinical context. We need to organize the clinical response by nurses or rapid response teams. And we need to learn much more about the optimal treatment of vital sign alterations in patients treated on normal wards. Thank you very much for your attention.
Hello everyone, my name is Frédéric Michard. I'm from Lausanne in Switzerland. So how to ensure high quality monitoring on hospital wards? First of all, by offering continuous monitoring solutions. We know from recent studies that because of the intermittent nature of spot check, nurses may miss a significant proportion of adverse events. In this study, coming from the Clement Clinic, nurses were spot checking vital signs every 4 hours and missed 82% of hypoxemic events, 79% of hypotensive events. In addition, we already know from large clinical studies, before-after implementation studies, that continuous monitoring on the wards may be associated with a significant decrease in the number of rescue interventions and in the number of ICU admissions. We also need robust connectivity. It was, I think, nicely illustrated by this study, where clinicians used wireless sensors with Bluetooth connectivity to monitor patients from day 1 to day 7. And so in green, it's actually when they were able to get continuous information. In red, it's when they had problems with connectivity. And you can see that if for some patients, obviously, they were able to monitor them almost continuously over these 7 days period. For other patients, it was much more challenging. So for that reason, I believe we need medical grade connectivity protocols to ensure truly continuous monitoring on the wards. Sensor accuracy is, of course, needed. I'm just going to use the example of respiratory rate monitoring. You know, respiratory rate is the most sensitive marker of clinical deterioration, and many different methods and techniques have been proposed to monitor respiratory rate, but they are not born equal. So here you have the example of an adhesive patch using ECG variability and accelerometer data to compute respiratory rate. It was tested in this study published a couple of years ago in anesthesiology, and the others showed that only 77% of the measurements were in the zones A and B, which are the safe zone from the Clarke rate. In contrast, this new wireless monitoring system that uses impedance pneumography was tested in this recent validation study published just a few months ago in Journal of Clinical Monitoring and Computing. And as you can see, more than 99% of the measurements were actually in the safe zones A and B of the Clarke rate. So how is it possible? As you can see, these new monitoring systems includes 3 electrodes, which are at least 20 centimeters apart, explaining that the system is able to record pretty large changes in thoracic impedance, at least much larger than what could be recorded with a single adhesive patch. In addition, because of these 3 electrodes, the system has a luxury to gather information from 2 channels at the same time. So if for any reason computing respiratory rate is not possible from one channel, very likely it will be from the other one. Mobile solutions are needed as well. I'm well aware there are solutions are usually described as stay-in-bed solutions like capnography and bed sensors. But we need to be sure patients can leave their bed as often as possible, even leave their room for physiotherapy. We all know that early mobilization is a key element of enhanced recovery after surgery programs. So we need monitoring solutions able to follow patients wherever they go. And last but not least, alarm management is key as well. Alarms have not been designed to disturb patients or to increase their level of stress. They have been designed to inform clinicians in case of clinical deterioration. So we need monitoring systems able to stay quiet, silent in the room, and to send information directly to a central station or to the pager or the smartphone of the nurse. So in conclusion, the requirement for high quality monitoring on hospital wards are continuous monitoring with robust connectivity protocols so that we don't miss any adverse event, accurate sensors, part of mobile monitoring solutions so that patients can leave their bed, even their room, and remain monitored, and smart alarm systems so that nurses are immediately informed in case of clinical deterioration, and patients can also recover in a quiet, peaceful atmosphere. With that, I thank you very much for your attention.